dear colleague, I'm Professor Charlotte Cordonnier from the Lille University Hospital in France, and it's my pleasure to meet today with Dr. Joji Kuramatsu, who is a neurologist but also a neurointensivist at the University Hospital in Erlangen, Germany. And today we will discuss about the results of Dr. Kuramatsu and colleague work, which focused on the association of intraventricular fibrinolysis with clinical outcomes in intracerebral hemorrhage. And to answer this question, they did an individual participant data meta-analysis. So before going deeper into the study, my first question, as I'm very intrigued by intracerebral hemorrhage in general, why did you focus on intraventricular hemorrhage?
Thank you, dear Professor Cordonnier. Thank you very much for the kind invitation. And let me just start out to thank all the collaborators of this study that we're able to conduct. And regarding your question, why did we focus on intraventricular hemorrhage? We know that IVH is an important predictor of poor outcome in ICH and mortality. And it is accessible. And that's always the questions. Do we have predictors of outcome that are accessible to treatment? And IVH is. And as we've seen within the CLEAR trial framework, interthecal alteplase reduces significantly mortality. And I think amongst neurointensivists, we were all a little disappointed that it actually did not translate into functional outcome at the end in this trial. I mean, signals were there. So our idea was to really look at a large data set in order to be able to explore in-depth associations in patients with IVH who receive intrathecal thrombolysis in order to be able to identify and specify those patients who may benefit from this therapy.
Okay, so could you summarize the methodology you chose to use to answer this question?
Yes, we conducted a systematic review of published studies to be integrated into our individual participant data meta-analysis. And there were only few studies who could be integrated. We did integrate CLEAR 3 and also patients from CLEAR 2 or A and B, and also another prospective study conducted at a single center. And overall, this patient or sample size was not sufficient. This is why we as lead investigators decided that we need more patients in order to be able to explore associations with IVF. And therefore, we conducted a search to identify large clinical cohort studies in ICH, and we extracted patients from those large cohort studies and integrated those patients into our IPD data set. And we finally ended up with 1,500 patients ready for analysis. And those patients were ICH patients and with a supratentorial ICH locations, with the presence of IVH, with occlusive hydrocephalus who received an external ventricular drainage. And those are the patients, 1,500, and we dichotomized treatment, those who received intrathecal alteplase compared to those who received standard of care treatment, so EVD management, and also the control group had those CLEAR patients integrated who received placebo treatment.
And do you think that across the studies you included, the standard of care, which means the trigger that led to the use of an extraventricular drainage was homogeneous, or do you think there's a difference among countries, for example?
So the great advantage was that we had really all data available, and we really meticulously took care that we had a homogeneous patient sample set, and we conducted extensive sensitivity analysis in order to exclude any heterogeneities that may be introduced due to the fact that we had multiple centers, multi-center participants, difference in from academic to tertiary care centers, difference in hospital characteristics, which was also addressed by our adjusted models.
Okay, so a really robust and thorough methodology. And what were the results?
So the final results were that beyond repeating the CLEAR 3 results regarding mortality, our primary outcome was 6 months functional outcome, modified Rankin scale 0 to 3. And the adjusted absolute treatment effect with IVF treatment was 9%, an improvement of 9% in favorable functional outcome MRS 0 to 3. Beyond that, when looking at secondary endpoints that we investigated, we did see an improvement across the entire range of MRS estimates by ordinal shift analysis with an odds ratio of 1.7. Mortality was halved with an odds ratio of 0.5 across the entire data. And I think most strikingly, the finding that we explored based on exploratory analysis and robustly adjusted in statistical models was the association of time and IVF treatment with functional outcome. Because we appreciated that if patients are treated within 48 hours after ICH occurred, that this yielded a robust increase in 6-month functional outcome for the entire IPD cohort by 15%. And we were able to validate this based on randomized data only from the CLEAR trial framework. And this treatment time window effect was shown there, yielding a 13% effect estimate to improve functional outcome with this treatment.
Mm-hmm. Okay, so maybe we could discuss the fact that, as you said, you confirmed the results from the RCT regarding mortality, but as neurologists, we are not just satisfied with mortality, so you go beyond. And intriguingly, you find where the RCT couldn't identify an effect on functional outcome, with your methods and larger sample size, but heterogeneity to some extent, you find an effect on functional disability. So how can you explain the difference? Is it just the sample size effect, or are there any other explanation?
Yes, thank you for this question. I greatly appreciate that one. And that is the big question. Why is IPD data positive regarding functional outcome and RCT data is not? And I think there are two aspects that we need to discuss. One is, of course, the inherent limitation of such a study design, that there is some selection bias introduced in this study that we weren't able to adjust for. And we used a doubly robust model to adjust for that. So we adjusted for all confounders associated with outcome, and we adjusted for all confounders associated with receiving the intervention. And when we compare our IPD data, just separating it into CLEAR trial data compared to the observational cohort data, we did see that the trial data, so in the CLEAR trial, involved almost 60% thalamic ICH patients. And thalamic ICH of the basal ganglia hemorrhages is associated with poorer prognosis per se, versus the observational cohort only included 45% patients with solely thalamic ICH. Another important thing, or another important difference between trial and observational was that the trial inclusion criteria led to less patients with a moderate or larger sized ICH, because the eligibility or inclusion criteria was based on a cutoff below 30 cc's. Those were the patients that were included into CLEAR. And we did see that with a moderate size ICH above 20, for example, in our exploratory analysis, those were the patients who really benefited more. So comparing observational to trial, there were only 14% of patients included into the trial with above 20 cc's and 44% of patients within the observational data. So maybe slightly larger ICH, moderate-sized ICH, those are the patients who may benefit. And this was also exemplified by a absolute treatment effect of roughly 20% in those larger ICH patients. So those were the main differences between the trial and observational data.
Okay. So maybe before concluding this discussion, okay, IVH is really intriguing. We can understand that in the acute phase of the ICH, the volume of blood in the ventricle may have a mass effect. So through this mechanism, we may understand why it has an impact of prognosis. But besides the mass effect, do you have any mechanistic hypothesis why IVH would be so important in the prognosis?
Yes. So time is a factor. It seems to be that earlier treatment has a larger effect on functional outcome. And what are the reasons that may be associated with this? And this is a hypothetical discussion in that kind of sense. What we do know is that once we have an occluded ventricular outflow, this leads to increased intracranial pressure. This leads to a global hypoperfusion of the brain. And the longer this occlusion may exist, the more subtle hypoperfusion changes or even damage could occur. This is one assumption. The other assumption that is intermingled or directly connected to it is the amount of blood in the intraventricular system. And we did also see that larger IVH volumes, or patients with larger IVH volumes, benefited more. And the more you extract out of the interventricular system, as also shown in CLEAR 3, the more the patients potentially benefit. So I think the inflammatory response initiated due to interventricular blood and then subsequently disseminated into the subarachnoid space, I think that this may be another important contributor, especially in the early phase with an inflammatory reaction. So it's neuroinflammation and hypoperfusion. Those are the two main pathomechanistic explanations.
Okay. Well, I think it's time to wrap up. It was a real pleasure to discuss in depth those results. And I think we can keep in mind that time is brain also in ICH. We are used to it in ischemic stroke, but it's true in ICH. And I hope that your results and this discussion will stimulate other researchers to focus on this devastating disease, which is ICH. So talk to you soon. Bye.
Thank you so much, Professor Cordonnier. Bye to everyone. Thank you so much.